Okay, we're going to get started. Hello, everyone. Thank you for joining us today. Now, let's take a minute to ensure that everyone in the audience is ready and comfortable with the technical aspects of this webinar. They're also being added to the chat. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language ASL capabilities enabled in this meeting. You can activate it by clicking the interpretation icon on your Zoom navigation menu or bar. If you need tech support during today's webinar, please send a chat message to the hosts and I will address it for you. Lastly, if you have questions during the presentation, please enter them into the Q&A area. The questions will be sent directly to the presenters and the moderators. Okay, next slide. So I would like to note that the views expressed in written conference materials or publications and by the speakers and moderators did not necessarily reflect the official policies of the U.S. Department of Health and Human Services and Substance Abuse and Mental Health Services Administration. Nor does the mention of any trade names, commercial practices, or organizations imply endorsements by the U.S. government. So my name is Cindy Rivera. I am one of the technical assistant specialists for the SAMHSA 988 Crisis System Response TTAC. And that's who's hosting our webinar today. SAMHSA has selected Altarum to provide training and technical assistance to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting, our corporation, and Change Matrix, who have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis system. The goal for the Crisis System Response TTAC is to support a crisis system that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. If you ever would like one-on-one TA, please follow the link in the chat and request that. I'd also like to acknowledge our SAMHSA partners that are here in the audience today. We are happy you're here and for your continued support in planning. Okay, now we're going to go over the agenda for today's webinar. I'm doing your welcome now, and we're going to move into speaker introductions, look at the core elements of prevention in child and youth crisis systems. We're going to talk about youth and family guided strategies. Then we'll move into suicide prevention and crisis services collaboration and wrap up with question and answer with our speakers. And then we'll move into office hours where anyone that has specific TA related questions can speak with me and some of my colleagues about that. Next slide. I am so excited to introduce our two speakers today. I've been able to work with both of them closely, and I believe they both bring a wealth of knowledge to this topic. Our first speaker is Dr. Tracy Levins. She is a managing director for the Center for Applied Research Solutions, and she has partnered across many systems to support children, youth, and families in behavioral health. She led the SAMHSA funded NTAC, the National Training Center for Children, Youth, and Family Mental Health. And she's also part of SAMHSA's programs to advance recovery knowledge. So welcome, Tracy. We are in great hands. And then we also have a great speaker, Lana Leip, and she comes to us from the great state of Indiana. She is the director of their suicide and prevention and crisis response. She oversees a slew of programs, and she really has a lot to offer in the approach Indiana has taken to collaboration. And she's also a clinical social worker, someone after my own heart, and a doctoral candidate. So welcome, Lana. And with that, I'm going to be passing it over to Tracy.
Thank you so much, Cindy. I appreciate your very kind introduction, and thank you everyone for being here today. I'm really excited to be here and appreciate this opportunity. I want to start by acknowledging the work that each of you do, whether you're coming in from a mental health agency or a substance use treatment agency or juvenile justice or child welfare or wherever you come. The work that you do supporting children, youth, and families is challenging. Sometimes it may feel like you're undervalued, but it is absolutely essential to helping our young people and families be successful and live healthy, happy lives. So thank you for being here. I also know your time is valuable, and I am grateful that you chose to spend this hour with us today. Today, we're going to explore the idea that crisis is not the start and what that means for how we build systems of prevention, partnership, and protection. Could we go ahead and go to the next slide, please? Thank you. So here you'll see our learning objectives, and I'm not going to go over all of them, but we're going to talk a little bit about some prevention-focused strategies, how youth and family guided planning can strengthen the crisis preparedness and reduce escalation, and how other systems can help support that. Can we go ahead and go to the next? Across systems, we're often brought in at moments of urgency when something has already gone wrong. Today, I want to offer a slightly different framing that crisis is not the start of something. It's a signal. It's a signal that prevention, connection, or coordination didn't fully line up. That's not about blame. It's about opportunity. So this presentation, we're really going to focus on how prevention, partnership, and protection can work together across systems to reduce escalation and support families earlier and more effectively. So as we go through this presentation, I really encourage you to think about your own communities, the families and children you work with, your own organization, and how some of these concepts might apply in your life. So let's start with something that's kind of obvious, but I don't know that we talk about it enough, and that's that a crisis rarely happens overnight. It rarely happens just out of the blue. Think back to a recent situation where you worked with a family or child in crisis. Maybe it was related to a needed psychiatric hospitalization, or there was violence in the home, or a child had to be removed from the home, or someone expressed thoughts of wanting to hurt themselves. When you look back at the timeline, you may be able to see some of those other signals, some of the stressors that led up to that moment of crisis. Maybe there were increasing absences from school over this past several months, or maybe a parent lost their job and they've been really struggling financially. Maybe there's a breakup or a loss that the young person experienced and hadn't really been able to process. Maybe there are arguments at home. What we know is that crisis, that acute moment when everything began to just boil over, is rarely the beginning of the story. Instead, we want to think about how crisis is a symptom. Next slide, please. When we see a crisis, what we're really seeing is the moment when all of those underlying challenges, the stressors, the unmet needs, and risk factors finally reach a breaking point. So if that's true, if crisis is a symptom and not the starting point, then where should we be focusing our energy? We know that traditional systems have focused a lot on crisis response, and that is absolutely necessary. When somebody's in acute danger, we want to respond immediately and effectively. But if we only focus on the crisis response, we're always going to be playing catch up. We're always going to be reacting. So what if we shifted our focus upstream? How do we put more energy, more resources, more coordination into preventing crises before they happen? Next slide, please. So I want to offer a little bit different way of thinking about it. Prevention isn't the absence of crisis, it's the presence of protection. So I feel like this is a critical distinction because we're not just trying to stop bad things from happening. We're not just trying to eliminate risk factors, which it's important, but what we're really trying to do is actively build the protective factors, the relationships, the resources, and the supports that can help create a strong buffer against a crisis. Think of it like building up an immune system for a community. We're not just trying to keep the viruses out, we're really trying to build up that body's capacity to fight them off when they do show up. So, how do we do that? How do we build up that protection? Next slide, please. So we can increase a family's protection by intentionally focusing on three different things. The first is protective factors, the second is early identification, and the third is community-based supports. So we're going to dive a little bit deeper into each of these. Next slide, please. The first is protective factors, and I think most of us have had some experience with protective factors for youth mental health. They're the characters and conditions that are associated with a lower likelihood of problem outcomes. The CDC describes them as factors that support healthy development and help buffer stress before it escalates into crisis. So what does that mean in practice? Well, it's things like positive coping and emotional regulation skills. When a young person has the tools to manage their emotions, when they can recognize what they're feeling, when they can name it, when they know healthy strategies to deal when those feelings feel like they're getting so big, that's a positive protective factor. Strong family connections. This doesn't mean you have to have a perfect family. There's no perfect family. This is about a relationship with a person in the family, whether it's a parent or whether it's an extended family. But it's one person in the family who the young person really feels sees them and has their back. Supportive and stable relationships, this even goes beyond the families. It may be another positive, caring adult outside of the family that really cares about them. That's one of the most powerful protective factors around, is when a young person has at least one stable, caring adult relationship with another adult. Young people actually thrive when they know what's expected of them. So clear expectations and structure and predictable routines, those are all protective factors too. Strong social connections. This is really about that sense of belonging, whether it's part of a community, part of a friend group, a team, a club, a faith community, cultural group. When young people feel connected and that they matter to other people, is tremendously protective. And of course, access to employment, housing. When we're able to really help families who are struggling with basic needs, that serves as a protective factor for the entire family. Now, what we know is that the CDC's research on youth mental health shows us that protective factors significantly increase the possibility of young people experiencing positive mental health outcomes. Strong social connections and stable relationships aren't just nice to have, they're essential buffers against adversity. And here's what I love about protective factors is that we can intentionally build those. We can design programs or policies or practices that actively strengthen the protective factors in young people's lives. When a school creates a mentoring program, when a community organization offers after-school programs, when kids feel like they belong, those are all active, intentional protective factors. And every single one of those can help prevent or reduce the likelihood or intensity of a crisis. Next, please. The second is really about early identification of situations as signals. What we know is that most crises are preceded by some sort of a signal. We might see changes in behavior, we might see school attendance or mood or increased family stress. The warning signs are usually there. But here's the challenge, and I wonder if it resonates with your experience. Often different people have different pieces of that puzzle or the picture. So a teacher might notice that the young person is disengaged or isn't staying up with the assignments the way they're usually doing, or maybe the kid got a disciplinary referral and the assistant principal says, what's going on, and there's an explanation behind it. And at the same time, maybe the young person isn't going to basketball the way they used to, or the pediatrician sees that they're losing weight, but is explained because the kid talks about how they're running more. Everybody has a little different piece of the puzzle. But if we put all of those pieces together, we would see a pattern. We would see a young person who's struggling across multiple domains of home, school, family, and community. But because everybody only sees their little slice, nobody's able to connect the dots until something dramatic happens, whether that's an arrest, a hospitalization, a suicide attempt. And that's why cross-sector communication and coordination is so critical. When we break down our silos and create systems where information can be shared appropriately with proper consent and privacy protections, we can begin to identify those patterns much earlier. And this is where those tools like screenings in schools or primary care offices and warm handoff protocols between services and systems or multidisciplinary team meetings, all of those can make a huge difference because we can create structures and facilitate that early identification. That will enable us to put the pieces together and see the patterns before they escalate. We can also normalize safety planning for families, just like we might talk with our young people about what do you do if we have a fire? Well, we're going to go downstairs and you're going to go out the front door and you're going to meet by the front tree. Or if we get separated at the mall, this is who you go to and this is what you ask for. Or if they're older and they have their first fender bender, this is what you do and this is how you do it. But if we can normalize safety planning for all families, here's what we do when we feel hopeless or helpless. These are the steps we're going to take. Here's who we're going to call. This is what can make us feel better. This is what I want as a way of intervening to help me feel better. Next. And that brings us to the third pillar, which is community-based supports. We know that support starts in the community. Families don't live in hospitals or agencies or agency offices. They live in neighborhoods. Kids spend their days in schools, on playgrounds, at the library, at the rec center. Families gather at faith institutions or in community celebrations or ball fields. If we want to truly support families, we need to meet them where they are. Services and supports need to be accessible and responsive to the unique needs and culture of the family and woven into the fabric of their daily lives. And this means thinking beyond traditional clinical settings. Therapy and psychiatry, yep, they have their place. But what about those after-school programs that give kids a safe place to go and positive adult relationships? What about the parent support group that meets at the community center? What about the peer support specialist who has lived experience and connect with other families who are going through the same thing? What we know is that community organizations are often the first place families turn to when they're struggling. Before someone calls a crisis line, or they go to the emergency room, or they even call a mental health provider, they might call their pastor, or they might talk to a trusted adult at the ball field, or they might reach out to a community organization or talk to the school. So when the community touch points are connected to the broader system of support, we can intervene earlier and more effectively and prevent a crisis. Next, please. So we've talked about all the protective factors, the early identification, the community supports, and those are all critical pieces. But here's the question. How do we put these together in a coordinated way? And this is where the system of care approach comes in. The system of care approach can really be the container, the safety net that holds all of these pieces. And let me explain what I mean. Next slide, please. So the system of care framework is a transformational approach to coordinating child, youth, and family serving services and supports in a community. Notice I said coordinating. It's not about creating new programs. It's not about inventing something from scratch. It's about taking the existing resources and programs and services that already exist in a community and organizing them in a way that's more effective, more efficient, and more responsive to what families really need. It's not a program. It's not a single intervention. It's an approach. It's an organizing framework. It's a way of thinking and working together. And when system of care is done well, it fundamentally changes the experience for families. Next, please. So we're going to take a quick survey, and I think our tech folks are going to launch the survey for us. but recognizing that we all come in with different levels of experience around system of care, I'd like for you to indicate where you are. Take a few seconds to respond to the poll and let us know where you are. It may be that you've been doing system of care for 20 years and you could teach a course on it. Or maybe you've heard of one in your community and you've been a peripheral piece, or maybe you've heard about it a little bit, but you can't remember the details, or maybe you're, wait, what? The system of what? So go ahead and take a second and indicate where you are. We'll give it just a couple of seconds. All right, can we go ahead and see some results now? All right, so we've got a pretty good split. We have a few people that this is new information, and a few says heard about it but can't remember the details. So we've got a nice little bell curve going on there. Thank you so much. Well, all of you will be able to know what it is by the time we're through. So thank you for doing that. Next slide, please. So let's go a little deeper. As you'll see, there's a formal definition, and I'm not going to read all of it, but I am going to pull out the really critical pieces. And those would be, it's a comprehensive spectrum of effective services. And you'll see that it's children, youth, and young adults. And either they have or they're at risk for mental health or other challenges. It's part of a coordinated network of care. It builds meaningful partnerships, responsive to the unique needs of the kids and families. And the whole goal is to help children, youth, and families function better at home, school, in the community, and in life. Now, here's what makes it maybe a little bit different. It's not just about treatment. It's not just about intervening when there's a problem. A system of care really incorporates the full continuum of support: mental health promotion, prevention, early identification, early intervention, including in crisis services and treatment. It addresses needs at every level, from universal supports that benefit all children and families to those targeted supports for those that are at elevated risk, to the more intensive services for those families with very significant needs. And we think about it usually as a pyramid. I didn't include the pyramid picture in this presentation, but you can think about it as a pyramid, with that bottom level being those things that are available to all the families in our community, and then the middle level being those more targeted services to kids that are already starting to demonstrate that they need additional support. And the tippy top of the triangle are those more families that have more intensive needs and need that ongoing intense level of support. And the beauty of this approach is that it meets families where they are. You don't have to be in crisis to get support, but if you do need that level of intense service, there's continuity and coordination throughout. Next slide, please. Now, you might be sitting there thinking, all this is fine and good, but is it really relevant to me? Because I am, and fill in the blank. Maybe you're a teacher or a child welfare worker or juvenile justice provider. Maybe you're a rec center person and you just happen to be on. The answer is yes, absolutely yes. You are a critical part of this. You are relevant, and it's relevant for you. The power of the system of care approach is that it brings together all the different sectors that touch the lives of children and families. No single sector can do this alone. We need everyone at the table. And the magic happens when all of those folks that you see on that slide work together in a coordinated way, because that's when we can provide families with comprehensive, coordinated, seamless support. Next slide, please. So you'll see there are three basic elements to the system of care framework. We've got philosophy, we've got the infrastructure, and we've got the services and supports. So the philosophy, that's our core values and principles, the fundamental beliefs that guide our work. The infrastructure, these are those partnerships and organizational arrangements that hold the system together at the community or sometimes regional level. And then third, there are services and supports. And these are home and community-based interventions or treatments, resources that are individualized to each family and delivered in alignment with the system of care values. All three elements need to be in place to really approach the work effectively. And we'll talk a little bit about each one. Next, please. So the real foundational element of the system of care is our core values. It's really the heart and soul and guides everything else in the system of care approach. The first is family and youth driven. This means that families and young people are supported in determining the types of treatments and supports they receive. And then also, they're involved in decision-making roles, not just in their own care, but in systems level policies, in procedures and priorities. And we'll talk more about that in the next slide. The second value is community-based, that a system of care approach really prioritizing keeping children and families safely in their natural environments and in the least restrictive environments possible. And there's also a little bit of an infrastructure piece here in that the responsibility for the system design, for the management, for the accountability is in a supportive infrastructure that's based in that community or regional level. And what this means is that communities have ownership and decision-making authority for their system of care. It's not planned up here and you just implement it. It's what does our community need to really benefit children and families here in our community? We know that communities know their own needs, their strengths, their resources, and we want to make sure they're empowered to design solutions that work for their particular community. As an example, one community I worked with in the past recognized that they were sending lots of kids and lots of money outside of their county and sometimes out of state as well, so that they could access out-of-home care. This county did an analysis of all the funds that they spent across the system. So they looked at child welfare, they looked at juvenile justice, and they looked at mental health. And what they found out is that they were spending a huge amount of money to send a fairly small number of kids out of state, out of county to receive care, and that the outcomes were mediocre at best. I think it was like 1 in 3 kids actually experienced a positive outcome as a result. And so what that county did in their system of care is they said, instead of sending our money and our kids outside, we're going to keep both of them in our community. And so they were able to concentrate that money on developing the services they needed to keep those children safely in their own communities, often in their own homes. And as a result, the money and the kids stayed in the communities. It cost less money overall. The youth and families experienced better outcomes, and the kids didn't have to be moved out of town or out of state. The third core value is around really being responsive to the unique needs of the child and family. We know that we want to make sure that the system of care is designed and adapted to meet the specific and unique needs of each child and family. And that means their linguistic and cultural responsivity as well. And it means going beyond just translation services, those are important, but really looking at understanding and honoring where each family's identity comes from. Understanding their traditions, their beliefs, their practices, their religious involvement or not. It means recognizing that different communities have different concepts of mental health, wellness, help seeking, and healing. And it means being able to meet those families where they are. Next, please. So as promised, here's the other little slide I want to talk about with family and youth driven. You can see that part of it is absolutely, yep, youth and families are experts on their own experiences. They get a voice and choice. They have access to peer support, all of those things. But the more unique part is we really want them to be part of the advisory board, part of when we think about planning, implementation, evaluation. We want them involved in every aspect. And so at the system administrative level, we might see them on those advisory boards and governance bodies, policymaking committees, not token representation, but true partnership with decision-making power and input into every aspect of our care. Let's go ahead to the next slide, please. So that was kind of the system of care values. Now we're going to talk about the infrastructure. So there are 4 main parts: the partnerships, the governance, workforce, and evaluation. Next slide, please. When we talk about cross-sector partnerships, the key question is, if the goal is to create a system of care that works for your community, who needs to be at the partnership table? So we know that as part of the system of care, you'll want youth and family partners. You want genuine partnership with either youth and family run organizations, if you have them. If you don't have them, you want youth and family representation from multiple organizations. You need system partners, and you see the list there: mental health, education, child welfare, Medicaid. You want community partners, whether that's housing or sports and rec or faith-based. Everyone brings different perspectives, different resources, different expertise, and different connections. And together we can create a comprehensive network of support that's much stronger than any single entity could do alone. Now, building and maintaining these relationships is hard work. Different sectors have different funding streams, different regulations, different cultures. Getting everyone aligned takes time, patience, and intentional effort. But once you have true collaboration across sectors, the impact is exponential. Next, please. So the second element is really talking about governance. And you see from the slide, it's a structure for decision-making at a policy level. And we want to make sure that it has legitimacy, authority, and accountability. Effective governance structures usually include representatives from all the key sectors and stakeholder groups, including youth and families. It has clear roles and responsibilities. It has transparent decision-making processes and accountability mechanisms. Good governance ensures that the system stays true to its values, responds to changing needs, and has the authority to actually make things happen. And this group is about, what do we want for and from the families in our community? How can we structure our systems in a way that benefits them most? That's kind of the prime directive of that governance structure. Next, please. The workforce development, one of the things that we know is critical is that people across all sectors understand and embody the system of care principle within a system of care. And so that means we need to do some work around workforce development across the systems. And for example, if we say we value family-driven care, but then staff members are trained in the therapist is the expert model, then there's going to be a disconnect. And so when we talk about workforce development, we want to make sure to embed those system of care principles and values in recruitment and training. We want to facilitate cross-training so that people from different sectors have a good understanding of what their colleagues in the other roles are working on and dealing with. It means having trainings that are co-presented by staff and youth or family. We also want to think about that pipeline approach. What does it really mean to build a system of care beginning with our youngest professionals? Maybe they're even still students. How do we build those values in? How do we build the expectation that youth and family have a voice in the planning, the implementation, the evaluation? We want to make sure and understand that it's not a one and done training. It is around providing coaching and mentoring and technical assistance and support as we move forward. And it also means that we need to focus on the preparation, the recruitment, and the retention of the mental health workforce across all sectors. I think for a long time, we've kind of gotten used to the idea that maybe mental health can poach a therapist from juvenile justice, and juvenile justice poaches a therapist from child welfare, and child welfare recruits somebody from the mental health provider. And so how do we as a community and as cross-system representation really build our workforce together? Next, please. And the final element in the infrastructure is really around the evaluation. We know that evaluation serves multiple purposes in a system of care. It informs the planning, helps us understand what's needed, where to focus our resources. It supports informed decision-making, meaning it gives governance bodies and administrators the data they need to make good choices. It documents our outcomes. It promotes sustainability, and it assesses effectiveness. Good evaluation in a system of care isn't just about counting services or tracking outputs. It's really about understanding whether children and families are actually experiencing better outcomes. Are they functioning better at home? Are they doing better at school? Are they doing better in the community? Are we seeing the number of crises or the intensity of crises decrease? Are families feeling empowered and supported? Next, please. And the final piece is really those system of care services and supports. This is where families actually experience the system of care. This is where the rubber meets the road. As we've talked about a little bit already, service delivery really needs to align with the system of care values. Practically speaking, this means that we start and end with youth and families. They determine the type and mix of services and supports. They're full partners in all aspects of their care. We want to make sure that those services are community-based, that they're responsive, developmentally appropriate, and we want to make sure that we have coordination to a flexible array of services and supports so that it's easy in, easy out as they transition from one level of intensity to another. Next, please. The system of care approach also creates connected communities. And what we mean by that is that we know that community-based organizations enhance and expand the array of available services. And we know that sometimes those faith-based organizations, those community providers are the very first place that a stressed family might go to try and get help. These community touch points matter immensely. When they're connected to the formal system of care, when there are pathways for warm handoffs, when community organizations are included in the network, when there's mutual respect and collaboration, when that pastor that the family reached out to knows who to refer that child and family to access services, we can catch problems earlier and provide support in ways that feel comfortable and accessible to families. And you can see a list there of some of the organizations that are often included in systems of care. Now, when these community anchors are connected to the formal system of care, we can create multiple entry points for support. No family has to navigate a complicated system alone. They have trusted relationships and warm handoffs at every aspect. And that's what we mean when we say a connected community. It's a web of support where families can access what they need when they need it in a place that feels most comfortable to them. Next, please. So to return to the beginning, we began by talking about how prevention isn't the absence of crisis, it's the presence of protection. We've talked about the 3 pillars of that protection. We talked about protective factors, we talked about early identification, and we talked about community-based supports. Then we explored how the system of care approach can really provide the organizational structure to bring all of those elements together in a coordinated framework. We know that that approach includes things like families and youth are in the driver's seat. They're not in the back seat. The family is not along for the ride. They're actually driving the car. We know that support happens in the community, not just in offices or emergency rooms. We know that system of care is really about systems talking to each other and coordinating with each other. We know that crisis response is a bridge to ongoing support. It's not a dead end. Because we know that even with the best prevention efforts, crises will still happen. And we can use that moment as an opportunity to connect them to those longer-term resources and the ongoing supports. And what we know is that when these things are in place, the family and youth leadership, the community-based systems and services, the systems coordination, and crisis response connected to ongoing care, crisis becomes shorter, safer, and less disruptive. The system of care approach gives every community the ability to build this protection that families need. It's not a quick fix. It's not a program you can just purchase and implement. It requires real commitment, real collaboration. It requires time, and it requires a true culture change. But the communities that have done this work will tell you it's worth it, and the families will tell you it benefited them. Next, please. So these are just the key points. A crisis is a signal, it's not the starting point. We know that protective factors can help reduce the likelihood of crisis. We know that youth and families drive the approach, and we want to normalize that safety planning for all families. So next, please. Okay, I think we've got one more slide. Yeah, So before I hand it over to Lana, I just want to remind you that the work you do every day matters. Every protective factor we help to build, every early intervention we make, every system barrier we break down, every partnership we strengthen, it all contributes to preventing the next crisis for a child or family. The work is challenging and sometimes it's slow, and sometimes there are days when it feels like you're pushing a boulder up a hill, but it matters. It matters to the system, it matters to the families, it matters to the young people. So thank you for the work you do every day. Thank you for being here. Before I turn it over, if you'd like to dive deeper into the system of care approach, feel free to access the system of care toolbox that we've launched. It's in that website. You're also welcome to email me at any time and I'll help you get connected. You're also welcome to click on the CARS website when you get the presentation deck and learn more about the Center for Applied Research Solutions. So thank you very much for your time and attention. It is my privilege to turn the microphone over to Lana Leip. Lana, all yours.
Thanks, Tracy. Nice work. I appreciate learning from you. So as Cindy mentioned, I am a doctoral candidate, and I share this because I graduate in 85 days, and I am counting down every single one of them. So I'm really happy to be here. So building on what Tracy shared, I'm going to give an example of what we're doing in Indiana. So we're going to talk about MRSS and how we're building that on our existing crisis response system. We're also going to talk about the core challenges that we're facing, as well as the strategic goals that we've identified to handle those challenges as we implement MRSS in the state. And then most importantly, we're going to talk about how youth and family voice really is at the heart of everything that we do. Next slide, please. So this graphic shows Indiana's full crisis continuum from prevention all the way to postvention, and I'm sure that it's familiar to you folks on the call, but I do want to spend a moment here because understanding the full arc of the crisis continuum really is going to help us understand where MRSS fits and why it matters as we go on today. So if you're looking at the slide at the very top where it says crisis prevention, this is our upstream work. And so this is things like mental health literacy, the way that we provide that in schools, suicide prevention programming and access to outpatient care, routine screenings, the community education that we're providing, and so on. And then right in the middle is where the acute crisis response often occurs. So you see that someone to contact, that's our 988 contact centers, someone to respond, those are our mobile crisis teams, and then a safe place for help, those are our crisis receiving and stabilization sites. And so when a child or their family is in crisis right now, this is the intervention that meets them where they are, right? It's not in the ER, it's not with a police officer, but really with a trained, compassionate team in their home or community right when they need it. And then we have postvention down on the bottom. And this is the support that comes after a crisis, right? So after a death by suicide, after the crisis has ended, after a trauma. But this is also one of the most underfunded parts of the continuum. And so I want you to remember that none of these pieces work in isolation, right? So a gap in prevention means that we will have more acute crises, and a gap in response means that we'll have more ED visits and hospitalizations. So a gap in postvention also means that the cycles of loss and grief will likely go unaddressed and perpetuate future crises. So Indiana's really been working hard to strengthen each part of the continuum. And what we've found so far, and what I know you all know, is that the continuum works best when it's designed with children, youth, and their families, not just for them. So that principle is really going to come up again and again today. Next slide, please. So MRSS stands for Mobile Response and Stabilization Services, and it's a comprehensive framework that provides crisis de-escalation, stabilization, and linkage to services available to youth and their families up to the age of 21. In Indiana, though, the age of 21 can really be flexible, as we're really trying to focus on those living with IDD or other, more complex needs. We're really not in the business of turning people away. So 21 is just a way to give us a container, but it's not a hard and fast rule for us. So for families who do need more ongoing, support beyond the initial crisis, right, beyond when mobile crisis has gone out to their home, stabilization services, provide 6 to 8 weeks of this intensive community-based coordination, which is a wraparound style of support that connects children, youth, and their families to their natural supports, some clinical services, as well as long-term care. And so, again, the families can receive MRSS services for 6 to 8 weeks. So, what makes MRSS different from what most of us are used to is traditional crisis systems were built around adults. They've often been, really deficit focused, and they're frequently ending in more restrictive responses as the de facto mental health provider, right? Like, so we've got ERs, we've got inpatient units, or we've got justice involvement really operating as these de facto mental health providers, which we know is inappropriate. So MRSS is built on this child and family centered philosophy that crisis is defined by the person experiencing it, as that very core principle, and that families and their partners are also. I'm so sorry. Families are the partners in the response, right, from the very, very beginning, and the goal really is to stabilize folks, in the community. So they receive these services in their home, their school, at a park, their grandparents' house. The team's goal is to de-escalate, assess, and stabilize them in the community, not in an emergency room. So, for instance, if a caregiver is calling 988 and they're saying that their 10-year-old kiddo is throwing a tantrum, right? We're focusing on the kiddo in this call. It's important to note that the family member is also likely at their wits' end and maybe experiencing a crisis themselves. So that's really where MRSS kind of comes in and thinks about this like system approach. So the caregiver who is in crisis can also likely benefit from a response as well. And so it focuses on everybody being involved, not just the person being focused on like the kiddo throwing the tantrum. So nationally, MRSS programs, have been shown to reduce ED visits and inpatient hospitalizations, as well as increasing family confidence in managing future crises, which is huge. So this is truly the crux of what MRSS is and how it makes it different, from the services that we've been providing before. Next slide, please. So the map that you see on the screen is what Indiana's crisis continuum looked like just a couple of years ago. So around this time, we also had an environmental scan done to determine our readiness to implement MRSS statewide in our crisis response. And so the scan really assessed to see the strengths and the gaps that we have specifically as it relates to the children, youth, and family care. So a lot of the strengths that we found were nearly all of the providers endorsed a person-centered definition of crisis. That crisis is defined by the caregiver and the youth, not by the provider, that's really big. Our teams also had a strong connection point to 988, which is how they are dispatched when someone is experiencing a crisis in the state of Indiana. And some gaps that we faced at the time of the assessment, there were only a handful of mobile providers who offered in-person team responses for every single call. Most of them at that time, this was again a couple years ago, sent a team if the caller specifically requested one. A lot of this was due to workforce shortages, capacity building, and all of that, not because they didn't want to, but that was a really big challenge at the time. But MRSS's best practice is that a team should be offered for every call. The response time targets at that time were met about by half of the mobile crisis responders. So they were taking longer than what the target metrics were supposed to be. And again, that's 24/7, 365 availability was also not universal. So a lot of those challenges were coming into play. And then only two of the providers surveyed were offering anything resembling stabilization services in the community. So on cross-system collaboration at the time, our partnerships with schools and behavioral health and law enforcement were starting to become some relative strengths. But in terms of juvenile justice, IDD systems, family and youth organizations, as well as poison control, those were areas that were identified in the scan as significant underdevelopment. Importantly, zero providers had any specific MRSS training or structures to their teams, which makes sense because we were just starting to try to implement that in the state. And so this is the landscape that is serving as our foundation forward. Next slide, please. So really exciting. As of January, so just a little over a month ago, we finally have full coverage across all 92 counties in the state of Indiana. So if you look at the shades of green across the counties, those are everywhere that serve mobile crisis. If you look at the little phones, you may not be able to see it super well, but it's the light blue phones. Those are where our 5988 contact centers are. And then the little travel boop that you see when you're have your GPS on. Those are where all of our CRSS sites are, which are our subacute crisis receiving and stabilization centers in the state. So at this time, this is really exciting. All of our three pillars, though, are still largely focused on the response practices for adults. So even though our providers express a strong desire to provide tailored services to children, youth, and families, including that stabilization piece that MRSS focuses on, we are really, in the thick of it, trying to figure out policies and infrastructure, payment systems, and all of that. So we're also at this time in the final stages of completing our 5-year state suicide prevention plan, which has been quite the undertaking. And it is required by Indiana code. So my team is charged not only with the creation and the dissemination of the suicide prevention plan, but as well as the implementation and maintenance of it. And two big components of the suicide prevention plan are involving focus on those with lived experience and living experience, as well as taking a lifespan approach to care in every single step of what we do for our programming, for our infrastructure and governance. So all the work we're doing with our suicide prevention plan is informing the rollout of MRSS in Indiana as it relates to the needs of all Hoosiers. So to move forward, as we started really trying to think about what does MRSS look like in the state of Indiana, because everybody does it a little bit differently. We want to make sure we're meeting the needs of our communities. We realized very, very quickly that we needed help and a lot of help. So we had the very distinct privilege of being chosen for the TTAC's Children, Youth, and Families Learning Collaborative with the awesome folks on this call today. And so for those of you who aren't familiar, that Learning Collaborative is a national community that takes place and focuses on children, youth, and families, their lived experience, and places them at the center of our crisis care design. So we were able to, in our time, which we're still receiving ongoing TA from them, we were able to really focus on facilitating peer-to-peer learning with different states who are trying to implement different policies, as well as conducting tailored exercises to really help us create the best continuum possible. So if you all ever get the chance to do it, I highly recommend it. They are a great group of folks. Darcy Gunn, who is on this call, is one of my teammates. And so after getting this, acceptance into the TTAC's learning community, learning collaborative rather, she built a 15-member team that focuses on leveraging Indiana's existing resources and services and strengthening our systems of care. So on the team, we have our suicide prevention and crisis response team. We've got DCS, the court systems, JDAI folks, the state Medicaid office. We've got BEADS, the Indiana Youth Advisory Board. So that is, those are youth peers who really help shape a lot of youth policy in the state, and the Department of Education. We've also had a youth with lived experience as well as a caregiver who has a lived experience with their loved one going through the crisis system. So we had a very comprehensive group of folks who are really coming to the table with a lot of strengths and a lot of knowledge. So because Indiana's extra, before the Learning Collaborative actually started, our team met and had 5 brainstorming sessions because we really wanted to get the most out of the Learning Collaborative as we could. So we wanted to come with a semblance of a plan so that way we could work with them to get like their knowledge to make it the best as possible. So during these sessions, we identified our challenges and gaps, as well as the strategic focus areas to help us map out what MRSS would look like in Indiana. And that's what we're going to walk through next. Next slide, please. So during the 5 brainstorming sessions, we had all of our team members, come up with the gaps and challenges that they see in their everyday lives and work. And absolutely surprising to no one, we ended up with a very, very long list of challenges. So we spent time sorting the challenges into themes, and we came up with these 3. So starting with resource and service gaps, our crisis system, like I've mentioned, was built primarily for adults. And the result of that is that children and youth really do often fall through the cracks, or they're sent to higher levels of acuity because we don't have anything existing, to help them before a crisis escalates or to give them a soft landing, once the crisis has ended. Um, so the stabilization services for youth in the state are also very few and far between for quite a few reasons. And so they're often referred to emergency departments or the juvenile justice system, which again, they aren't appropriate for the situation at hand. Over half of the counties in Indiana are considered rural, and we know that they face particular challenges with response time, team availability, and workforce. And even though we do have the Youth Advisory Board, there really aren't a whole bunch of youth or caregiver peers available. Most peer support positions are filled by adult peers who they themselves have lived experience. That's a critical component. But when we're thinking about what we're trying to build here, we want to make sure that we're including those others as well. We've also got population-specific needs. So I know everybody on the call knows that a one-size-fits-all crisis response just doesn't work. All families, their needs, their available support systems and preferences, they really do all look different. And so there's also this challenge, again, like I mentioned, of over half of Indiana's counties being rural. So everybody knows your business in a rural community. And so if you're going to get services or somebody's rolling up to your house to provide, crisis care, your neighbors are looking out your window and they know your business. So that's a really big deal that we cannot underscore enough. And we have to make sure that we're including, in our protocols. So also knowing, transportation challenges, long wait lists for specialized services, and the availability of resources that are there. There's just all of these things that naturally occur. And then also children living with intellectual and developmental disabilities, they're especially underserved. Our environmental scan from a couple years ago showed that 12 of the providers that we surveyed had absolutely no relationship with any of the IDD systems at all. And so that's a big gap, and that's an area of opportunity. So the other part too that we found was that only a handful of our mobile crisis teams reported even using a child-specific assessment tool when they did go out on a mobile crisis run. So tells us about a lot about how youth-specific our crisis care has been, well as where we can move. And then lastly, we've got the system navigation barriers. And so families in crisis, they shouldn't have to be system experts, but right now that's really how it's going because Indiana's crisis continuum is fragmented. So we're getting better, but there are multiple access points, inconsistent handoffs between 988 and our mobile crisis teams. We do have a directory for some of our crisis resources, but there's not this comprehensive statewide one where you can go and get everything that you need. And there's also a limited connection between the schools, the emergency departments, child welfare, and mobile crisis. So we're really working on that and trying to build those relationships, with the different providers. One of the things that I find interesting, I mean, I know I live and eat and breathe this work, but I'm always surprised when I hear folks even today saying that they don't know that 988 even exists. They don't know what the crisis response system is, nor how to access it or when it's appropriate. So there's a lot of education and socialization around this that needs to continue to happen. So we knew we couldn't identify these challenges correctly without the people being affected most really telling us what they are. So we have come up with, some very intentional strategies that we will get to now. Next slide, please. This was actually the hardest part, coming up with the strategic goals, because again, like I mentioned, we had this exceptionally long list of gaps and challenges that we're facing. And it's really hard to say, we're going to focus on this one piece and put this other one into a parking lot. So we really, really struggled with that. That actually took us quite a bit of time. And again, there's so many things we want to accomplish. So strategic goal one is to identify the barriers, the challenges for navigating the crisis system. Goal two is to increase school personnel knowledge and utilization of crisis resources. And then three is increase the awareness of youth peer support groups and stories of hope and healing. So each of these goals, which I'll get into more in just a moment, they also align with our suicide prevention plan, which is really helping us stay focused. That was how we ended up coming up with these three, is we were really trying to align with what we've got in the suicide prevention plan. So one of the ways that we're trying to accomplish this, so we have an interstate MRSS learning collaborative that Darcy, who's one of my teammates, has been meeting with over, I think, the last year or so. And so these are leaders in other states, I think Washington, Kansas, Kentucky, and Indiana. I might be missing another one. But these are really the leaders in the MRSS realm that we've met. And it's a very casual, very really cool call. And so the folks that she meet with, they're very fabulous humans who are all in different stages of MRSS implementation in their respective states. And it's been critical for the development of our program in Indiana. For instance, Darcy's been meeting with the amazing folks over in Washington who are just absolutely light years ahead of us. And they've been kind enough to really chat through some important considerations for building out Indiana-specific MRSS training. And because of their support, our team is currently working on building and actually the finishing touches of our MRSS training module that folks who serve our communities experiencing crisis, they will be required to take in order to be designated with the state. And so because of this group, this Interstate Learning Collaborative, it's really allowed us to stand on the shoulders of giants. And I can't express my gratitude enough to them. So out of the Interstate MRSS Learning Collaborative and our time with the TTACs Learning Collaborative, we decided that we really needed to work with our providers in state to help us lift this up. And so Darcy also, I know you all are catching a theme. Darcy's doing all the things, and she absolutely is, and she's wonderful. So she facilitates an Indiana-specific provider learning collaborative that is meeting core. So these are our crisis providers across the continuum who are getting together. They're doing resource sharing and peer learning. They're helping us at the state identify gaps and areas of opportunity, as well as policies and best practices that will best serve Indiana. So as a part of this, Darcy recently created 4 subcommittees within this learning collaborative based on the needs and our goals and our challenges that we're facing. And so the 4 subcommittees that have been parsed out are training, policy, data, and interoperability. And so interoperability is really how we're building our partnerships with law enforcement and EMS in our response. Like, when is it appropriate for law enforcement to respond, and when is it not? So lots and lots of things happening here. And again, most of them Darcy is building. So next slide, please. So again, our strategic goal is to identify the challenges for children, youth, and families who are navigating the crisis system. And so we came up with many challenges in our group. One big one really being that there's not a billable code that our teams can use in their response. So we have a mobile crisis code. So if somebody goes out on a run, excuse me, they're able to bill for that mobile crisis response. We also have the CRSS sites, which are, community centers that have the subacute stabilization model. We have a code for that, but we don't have a code for stabilization services when it's happening in someone's home. So we're asking these providers to go out and provide 6 to 8 weeks of care, but we really don't have a good billing mechanism for that. So that is something that we are actively trying to work on. It's a very long, kind of complicated process, but that, I mean, being able to pay the providers is key. Another thing that we've found is consent. So we're dealing with, children, youth, and their families, and we have laws around consent and when you can approach a kiddo and when you can't. How do we navigate consent at school or the doctor's office or if they're at their softball practice? So that's another big one that we're working with legal teams and different stakeholders to really parse out. Um, and so we're tracking a lot of this information to really consider how to implement these strategies to overcome these challenges. But we also know that those who are closest to the problem are also those who are closest to the answer. So we plan to do a series of listening sessions with our communities to really guide us with identifying the challenges that they're facing, such as what I mentioned, as well as solutions. And why does all of this matter? We know from research and from the families, that we talk to every day, that the experience of, seeking crisis help can, in and of itself, be traumatizing. So we've got long hold times, we've got being transferred between agencies, or even being, this is my favorite, even being given a phone number for a resource to be told that that number is no longer in service or that service is no longer there. They have a long wait list, or that the service, that agency doesn't even provide the service that you need. So that's really big and challenging. Another one that we often hear too is that, folks are afraid of being met at the door, by police when you're calling for mental health support. So we don't have this complete Indiana specific data on these experiences. And so that's exactly what this goal is trying to address. So again, we're going to do these listening sessions with the families and young people who have accessed the crisis system or who have tried and couldn't. And so we're trying to identify these specific audiences, who have been involved also in like child welfare, juvenile justice involvement, and then the underrepresented communities that can use the support. So this work really addresses two of our learning objectives. So we have this youth and family guided planning and this community responsive prevention. So the data from these listening sessions absolutely won't sit on a shelf. We're going to be using what we learn to build these very intentional policies and practices. Next slide, please. Goal two, so it's increased the school staff's knowledge of crisis resources. So again, this one was really challenging as we were parsing it out because there are so many stakeholders that we know need to be included. We've got doctors, we've got teachers, we've got administrators, we've got child welfare, and we've got all of these folks who need to be included. But we decided that we'd like to just be very focused and focus on the school staff and their knowledge of the crisis resources, such as 988, because they are the folks who see these kiddos day in and day out. They're also the pulse of their communities. They're administrators, they're superintendents. They know what after school sources are out there that the kids are going to for activities. And so we've overwhelmingly heard that folks in the school system are not familiar with the crisis system, let alone how it can support their students. So goal two is really about connection, where we can reach young people, before crisis escalates. And so if the schools, counselors and their teachers and the administrators don't know what exists or how to access them, the resource itself might as well not even exist. So really need to bridge that gap there. Next slide, please. And then our third goal is promote youth help seeking through stories of hope. So again, this goal really is about hope at its core. And it sits at the intersection of suicide prevention and crisis response. And so these two systems that operate often separate, but absolutely need to work together. And so one of the most powerful things that we can do in suicide prevention and crisis response is to show young people that recovery is possible. It's that someone was where they are and they found a way forward. So stories of lived experience really aren't just about being an inspiring or catchy slogan. It's reducing stigma, it's increasing help seeking and building community. Um, I have two kiddos myself, and they're at the age where their eyes absolutely glaze over when I try to have any type of serious conversation with them. So their friends' opinions at these ages and stages really mean a ton. And so we know that this youth peer connection piece is very critical, especially when they have their phones in front of them all the time, or they're seeing different types of media showing just the highlight reels of their peers or others about how great their lives are. So it's very easy for youth at this age to feel alone and vulnerable and like they're the only ones feeling this way. So we know that peer and lived experience, those voices are the most powerful tools in suicide prevention. And when they hear from someone who's been in a crisis and has found a way forward, they're more likely to reach out when they're struggling. So they're going to call 988. They're more likely to tell a trusted adult. They're more likely to find resources that are supportive and helpful. So in moving forward, we're really trying to focus this goal on getting away from that deficit model that we've historically operated from. We're trying to get away from just focusing on risk and assessing for severity and in intervening. We want to do a better job of circling back and amplifying these voices of people who have come through crisis and want to help others. And so this goal really changes that. We are connecting with individuals who have lived experience and who want to share their stories. So we're going to be hosting listening sessions with them to learn not only what they want to share, but how they want it to be shared, because at the end of the day, their story belongs to them and they get to decide how it's told. Um, so that is what we have been working on in the state of Indiana. I think that is my last slide. And I am happy to hand it over to Gia.